So, Dr. Desai, thank you so much for joining us here today. I just want to thank you for allowing us to have some of your time today to speak on COVID-19 and how this is impacting your practice. So I figured we could just jump straight into the interview. So the first question that I have for you today is, how is COVID-19 impacting your practice in Connecticut, and have you seen a surge in cases?
Absolutely. So I think, as everywhere in the world right now, COVID-19 has definitely impacted our practice of medicine here in Connecticut. And it's ranged from, we are restructuring hospital floors to make more ICU beds. There's been increase, geographical distribution of patients within the hospital. We are trying to minimize the iatrogenic spread, especially for patients with cancer and any other immunocompromised people. There's been setting up tents outside of emergency services to increase the bed availabilities. And then obviously it's also affecting, a lot of our discharge planning for the patients, because we've heard stories about the nursing homes having, surge in cases as well. So I think overall has definitely impacted the practice in the hospital. I think from the outpatient setting, I would say we are seeing more and more incorporation of telehealth at most of our sites as well. I think in terms of, in Connecticut, we've definitely seen a surge of, similar to other states. I think as of yesterday, we stand at somewhere close to 12,000 confirmed COVID-19 cases. And I think given our proximity to New York, I would say, we've still done fairly well. And although the cases have been reported in all, counties of Connecticut, and about 550 deaths also have been reported, unfortunately.
Yes, this pandemic is spreading a lot. I know there have been a surge in cases in other states as well. So do you think you could expand on some of the measures that have been put into place at your institution to prevent the spread of the virus?
Yeah, so I think we've made changes here at various levels. I've seen at ICU level, the ICU units have been actually split into a COVID unit and a non-COVID unit, again, to minimize, spread. There's been an increase in the number of mechanical ventilator devices. In fact, we've also seen that the ICUs have ordered more non-invasive ventilation devices, because we're trying more and more not to intubate these patients if they do not, or we can avoid as much as we can. I think at the level of medical floors, we have designated COVID floors in our hospital. We have a designated COVID team, and patients who do not need ICU level of care, they are generally obviously admitted to the medical floors. We've seen patients being moved geographically to make sure that they are away from the chemotherapy floors or any other floors where there is a high risk of transmission and the patients getting those infections. And I think at the ED level, obviously, every patient now with a symptom complex related to clinical features of COVID is, swabbed and isolated initially. We are preemptively starting them on treatments after discussion with infectious disease specialists. Although, we don't have a lot of robust data on it, but, when you're treating these patients clinically, you have to be able to kind of go into and do something more about it. So.
Perfect. And then speaking of data, you were the first author on a pooled meta-analysis looking at COVID-19 and cancer. So do you think you could discuss the objective of this study and how you selected which studies and data to include?
Absolutely. So I think the very early reports that came out of China about COVID-19 and cancer came from this one paper in Lancet Oncology, which reported a cancer prevalence of 1% among some 1,500 cases of COVID-19. This reportedly was higher than the overall cancer incidence in China, which is close to 0.3%. So, and obviously there have been a plethora of studies from China reporting, clinical features, comorbidities, and outcomes in these patients. However, this paper was really the first one which has discussed it from a cancer perspective. So we really wanted to know whether this was an anomaly or was this a consistent finding? Should we be concerned more for the patients with cancer as related to COVID-19? So the objective really of our study was to do a pooled prevalence analysis of cancer patients with COVID-19 from these studies. So we searched, we searched the normal databases like PubMed and Web of Science and Medline using the search terms of COVID-19 and malignancy or cancer. And we found about 276 articles, which was really 266 of them were either reviews or non-reported patient population. So we just really had to narrow down to these 11 studies, which have been included in the paper, which really talk about patients with COVID-19 and then identify the patients who had cancer. So we found, using these studies, we kind of wanted to find the pooled prevalence to kind of give an idea to the community of what's the risk of COVID-19 and how is it related to cancer.
And do you think you could speak a little bit about the findings?
So yes, so we found the overall pooled prevalence of cancer in patients with COVID-19 was about 2%. So if we relate back to the Chinese population, that's more than the 0.3% incidence that they have. And so we further wanted to do a subgroup analysis based on the sample size, because that was one of the limitations of the prior studies that were done. And we found that, even in patient population less than 100 COVID-19 patients, it was 3%. And in a sample size of more than 100, it was overall still 2%. So they regressed to the findings from these larger studies. And so this has then convinced us that, indeed the prevalence of cancer in these studies is in fact higher than the incidence of cancer in the Chinese population. And all these studies are coming out of China. So that also kind of gives us that uniform results from that. Also, just for the listeners, I would also like to give out the disclaimer that these studies only reported the prevalence. We do not know how many of these patients had a remote history of cancer 20 to 30 years ago versus how many of them have like active cancer at the time of analyses. We also have no granular data on the type of cancer, the type of treatments they are receiving and such. But I think still this study really tells us the risk of COVID-19 in our patients with cancer.
So patients with cancer and cancer survivors remain an important at-risk population for the virus. So do you think you could discuss the subsets of patients who require more intensive attention? So in your article, you did mention those undergoing bone marrow or stem cell transplantation, or those with hematologic malignancies, or those with active treatment. And also, how are you providing that attention in practice?
So again, I think some of the previously discussed studies have shown that patients with diagnosis of cancer have also like higher risk of severe events, which could be being admitted to the ICU, needing ventilatory support, or even death, compared to patients without cancer. Studies have shown that patients who underwent chemotherapy or surgery in the past month have a higher risk, 75% versus somewhere in the 40% range. So, and then there was a recent, study which is a preprint of observational study which just came out, after our paper, did in fact show that, lung cancer, blood cancers, or hematological malignancies and esophageal cancers, these patients have highest mortality and ICU admission rates when you're looking at a subset of cancer population. And this study also confirmed the increased severity of symptoms and the need for mechanical ventilation. So absolutely, I think we have to be very cognizant of the fact that this is an at-risk population, patients who are, lung cancer patients or patients undergoing active chemotherapy who are neutropenic, patients with hematological malignancies, those undergoing stem cell or bone marrow transplant. They all deserve special attention. And I think not only from their oncologists, but from their primary care physicians, from the hospitalists taking care of these patients, because they have poor outcomes. In practice, I think there have been changes in the way we practice. We are doing more of telehealth appointments, especially for the cancer patients or patients who are immunocompromised, to try and avoid from them coming into the hospital or the clinics and exposing them. I think among oncology, I think there has been a plethora of talk about switching from IV to oral regimens and trying to allow these patients to stay away from the hospitals when they can. We are risk stratifying patients to ensure that we do not expose them by calling them again in the clinic. So I think this has been how the practice has changed and how we are trying to give more attention to these patients.
Perfect. So you did kind of already answer this, but in case you do want to expand upon it a little bit more, are there any kinds of questions that arise for patients who underwent chemotherapy or surgery in the past month?
Yeah, so I think, again, some of these questions that arise is there's a lot of unknowns. We do not know whether these patients who, do get chemotherapy, should we be giving chemotherapy actively in these patients? Should we be delaying their chemotherapy, delaying their surgery? And I think there has been some comment about what different societies and different institutions are implementing, but I think there's a lot of unknowns and a lot of variables, and I think it's a case-by-case evaluation.
Perfect. And then how are you deciding when adjuvant chemotherapy or elective surgery should be postponed? And what do some of these discussions look like in your practice?
So I think these are really, risk-benefit discussions, which I think all of us have with the patients in many fields, and especially in oncology. I think there have been several efforts, and there are ongoing efforts to objectively assess what needs to be done and what can wait. However, things are constantly changing, and we are getting new data every day, so we don't have a fixed situation at this point. Like I said before, there are institution-specific guidelines. Then there are emerging consensus among oncologists and the community. I think a thought process that was really useful and that is really useful for these discussions was one that I really found interesting, was one which was recently reported by Dr. Hirschman and Dr. Bash. Opinion is to think about these at different levels of benefit. So we have to stratify these patients into one, which are patients we can potentially cure and where we must treat them because their cancer-related mortality is more than the COVID-related mortality. Then there's another subset of people who have moderate effect, who with the therapies will have moderate effect on their quality of life and overall survival, which again, we are trying to prescribe even marginally less effective regimens with lower infection risk to try and avoid these patients from being infected. We're substituting, oral for IV agents. We're doing more stringent neutropenia monitoring and treatment. And then there are the other subsets where, you're only going to have these patients have marginal effect on quality of life and overall survival. So that's a discussion when you have a metastatic cancer patient who's post third line of therapy, whether, it's worth it putting them at risk of this infection and getting worse. While you're not going to get much mileage from the, potentially a fourth line of therapy in that case. And then lastly, I think, the minimal risk is where, you have the patients with cancer who are cancer survivors or where you're doing cancer surveillance like colonoscopies. So I think that's really where we are, hitting them with remote care delivery and telehealth and trying to really avoid, seeing them unless absolutely necessary.
So moving a little bit back towards your article again, in your meta-analysis, you mentioned that there was no evidence of current indicates that there was an increased risk of pneumonitis in those receiving immunotherapy or radiotherapy. However, this is obviously an area of concern. So what are your thoughts on this?
So I think as we mentioned, I think this is a legitimate concern, especially given the mechanism and the bioplausibility behind it. However, not much data exists to really comment on that. I think it is too early, and still there's a lot to be discovered for COVID-19 and especially for COVID-19 and cancer. So I hope that we have emerging data on these clinical questions, which are applicable to practice.
Well said. And then what do you think your colleagues should take away from this meta-analysis?
So I think, we really wanted to answer our questions on the relationship between cancer and COVID-19. from the data that was out there. So we looked at the data, like I said, and it was inadequate in terms of the sample size. So we felt that there was a need to address this issue. And if we still, and we thought if we still find an increased signal for these COVID-19 in cancer patients, we should really impress that upon not just the oncology community, but the medical community in general, since this is really something an ED provider or a treating hospitalist or an oncologist will all see in the future. So I think the big takeaway is that patients with cancer are a special subset of the population, which should be given due attention during this pandemic. And now we have robust, in terms of the sample size, we have robust data with this study to say that.
And then are there any COVID-19 related challenges that you're experiencing that we haven't discussed yet?
I think the only other challenges I would say are the challenges that the healthcare system, the hospital levels, and even the personal challenges for physicians. I think it's a very stressful time for everyone, obviously most of our patients. And I think what makes it difficult is also it is a difficult time for us as physicians and our families. A lot of us are separating ourselves from our families, sleeping in the basement and working more than usual to see this through. And I think it is a remarkable effort for the healthcare systems worldwide, and we need more of it. But I think those are some of the other challenges which I think we have been experiencing here as physicians and everywhere else in the world.
Thank you for mentioning that. And then I only have 2 questions left for you. So my second to last question is kind of has to do with any other COVID-related studies. I know you did mention 1 or 2 previously. So were there any other ongoing research efforts that you were finding particularly exciting?
Yes, absolutely. And in fact, I'm very honored to be part of one such remarkable effort. It's the COVID-19 and Cancer Consortium, or CCC-19 for short. It is fascinating that the effort really started with a few tweets among colleagues, few tweets. And within a month, we are now a consortium of over 80 cancer centers and organizations who have all come together to collect data about cancer patients who have been infected with COVID-19. So our hopes are really to understand the demographic patterns, the clinical characteristics, the complications of patients with COVID-19 and cancer. And kudos to Dr. Jeremy Warner at Vanderbilt and the rest of the steering committee for their dedication. I think the pace with which this is moving and has seen the light of day, I think is really tremendous. So I'm very excited for that. And I think there are many similar efforts, societies like the American Society of Clinical Oncology, the American Society of Hematology, they are also doing similar efforts to have, collect data for patients with cancer and COVID-19. There is a thoracic cancer specific registry, so there's more and more crowdsourcing applications that are coming through in oncology specifically to look at the data. So yes, and I think in fact, being a trainee, being in the middle of a pandemic, learning about and evaluating the clinical characteristics of these patients, the associations and the new treatments that are coming through and studying those, I think is a very exciting time academically, but at the same time, it's a very challenging time clinically speaking.
Wonderful. And then my final question for you, Dr. Desai, is what do you feel is most needed to quell the pandemic?
I think in one word, if I had to say, I would say solidarity. And in fact, it's also the name given to the trial that the WHO has just started. But I think basically we need collaborations. We need collaborations among nations, between clinicians, scientists, and epidemiologists at the same time. We need people to collaborate with each other, which we are seeing hugely with social distancing. Everyone's looking after themselves, but also trying to look after other people, trying not to infect them. So I think we are seeing glimpses of it every day, and hopefully this union will provide us the right answers to the right questions to do right by our patients and our, the world citizens, really.
Well, that was a wonderful way to end this interview. So Dr. Desai, thank you so much for taking the time to speak with me today. and
Thank you
just
so much
help
for
us
having me.
spread your insight on COVID-19.
Thank you very much for having me.
Of course. Thank you so much. Have a good one.
You too.